Hello and welcome to the Swallows Charity Head and Neck Cancer Podcast. Join us on a head and neck cancer journey, presented by Derek Luthwaite.
Hello everybody.
And Chris Curtis.
Hello everyone.
We'll be discussing everything that patients and caregivers need to know about diagnosis, treatment, and so much more.
I'm CEO of the Swallows Head and Neck Cancer Charity, and I'm also a cancer survivor for nearly 10 years now.
And I became a caregiver when my wife was diagnosed with mouth cancer, and it certainly put me on a journey that I never expected to experience during my lifetime. Hello everybody and welcome to another edition of the Swallows Head and Neck Cancer Podcast. My name's Derek and I'm here with Chris. Hi Chris.
Hi Derek, nice to speak to you again.
Yeah, you too mate. How are you doing today? Are you well?
I'm doing very fine. Yeah. Life's good when you wake up.
This is always a bonus. Today's episode is we're very fortunate in that we have a CNS, a clinical nurse specialist with us today. And as we told you in one of the earlier episodes, on this journey that we go along as a cancer patient and a cancer caregiver, head and neck specialist area, obviously, we meet various people who have enormously critical roles to play. And today, I'm delighted to say a big welcome to Amanda Naylor, who is a CNS based in Milton, Keynes. That's correct, Derek. Hi, Amanda, and welcome to the Swallows podcast. Thank you very much for joining us. Would you, Amanda, just to start things off, would you just give us a very, very short introduction of yourself and the top line details of what the CNS role is all about?
Yeah, my name's Amanda. I've been a CNS at Milton Keynes Hospital since 2016, but I've been a CNS for nearly 11 years now. My main role is supporting head and neck cancer patients from the point of diagnosis, providing them with information, supporting them with decisions about treatment, symptom management, and being a pivotal person that can signpost or liaise with the other members of the multidisciplinary team. Okay, well, this is a fairly comprehensive role that you're fulfilling here. Sort of, people who are diagnosed with cancer are going to come across you at a very early stage of the journey that they start on. Is that correct? That's correct. So I may see patients maybe sometimes pre-diagnosis. It just depends on the sort of distress they might be in, even, at being told that they might have a cancer. Sometimes I might be involved at that stage, but the majority of the time it's when they're coming back for the information on their results, their biopsy results, and discussion for treatment. Okay, so you're working alongside the consultants. So I work alongside two head and neck consultants. We're not the main treatment centre. Patients will go off if they're having major surgery or oncology treatment to Northampton. So that's why there's a lot of liaising across different trusts. So just to enable that smooth transition and pathway for the patient. I know you're treating the patient, but you've got a caregiver sitting there usually as well who's supporting the patient. So you're talking to both. Are you just concentrating on delivering information to a patient, or are you wrapping this up in such a way as it gives the caregiver information that they can help the patient with? Yeah, it's a bit of both really, because you need ideally you do need an extra person there to take on the information, because sometimes the minute someone hears the word cancer they shut down. So the conversation does involve both the patient and the carers. And then what normally happens is once the consultant has delivered the information that they need to, I normally take them off separately and spend a bit more time rather than just letting them just leave the department in. Sometimes can be quite a distressed
state. So I try and sort of spend some time with them, go over anything they haven't quite understood, and they have my contact details. And I also have my own clinic that I can follow up again potentially the following week, and do what we call a holistic needs assessment, and just make sure that we're covering everything that might be concerning those patients at that time.
That's very interesting, because you've already mentioned something that I never came across in my journey. It was my wife who had the cancer, and I obviously was the caregiver. I never had this holistic meeting. I don't know what that is. Can you give us a brief explanation of what that's about?
Well, this is actually something where I first met Chris, was where we were both pulled in together to sort of discuss the EHA and the fact that it didn't necessarily encompass a lot of the things that were relevant for head and neck cancer patients. So that was where we actually first met. So what we do is we can set up the assessment as an online thing for the patients to do in the comfort of their own home. You can do it face to face, but I find it works better if patients can work through the assessment, which covers sort of physical symptoms and emotional symptoms and practical things that a patient might be thinking about following a cancer diagnosis. So for example, they might be worried about income being affected by having time off for treatment. They might be worried about family members, what to do about planning for the future, wills, etc. So it just kind of tailors any conversations you might have going forward, because we can all quite easily sit in a consultation for an hour and talk around things, and then a patient might leave the room and go, do you know what, I didn't ask about this. Whereas if they can go through an assessment and tick the things that they either want more information about, or they're really is causing them a lot of anxiety. So it kind of has like a score, like a pain score really, so they can tick the thing they're concerned about and then rate it on a 0 to 10 scale, and then that comes through to me. So all the high level concerns could be like 8, 9s and 10s, and they're the things that help me focus on either giving them more information, signposting them to a different service, or even just sometimes it's just talking through that with them, because there may not necessarily be anything you can help them with. But it just gives them that window of opportunity. And certainly when it comes to sort of more delicate topics like relationships and things like that, it's always one of those almost taboo subjects that nobody wants, the elephant in the room. Whereas if you're given an assessment and that patient ticks the box, it's there in black and white and helps that, sort of opens that door to that conversation.
That's remarkably interesting, and the question I want to follow up with here, Amanda, is do you talk to the patient and the caregiver as a duo, or do you give either or both an opportunity to talk to you separately?
So when we're doing the assessment, if the patient hasn't, and when I give it to the patient and they sometimes say, oh, my wife will help me fill it out, I normally say, but it must be your concerns and not your wife's concerns, because it's very easy to put words into someone's mouth. So I do try and stress that. And if I'm doing it face to face, I do try and if they want to both see me, I will try and do the assessment separately with the patient and have that opportunity to discuss things, because they might not want to necessarily let their carer or wife or partner know what's concerning them. So it's almost like a private thing. And then what if after we've done the assessment and gone through that, then I'll involve the partner in just discussing, sort of treatment, and give them the opportunity to talk through what they're worried about and what's going to happen, and help them support, and obviously signpost them to the Swallows.
You're listening to the Swallows Charity Head and Neck Cancer Podcast.
I have a concern here, and it's a personal concern that impacted on me as the caregiver with my wife. When we were being assessed, when she was being asked questions by the medical professionals, whether it be CNS, whether it be the consultant, the oncologist, whoever it happened to be, there were times when she deliberately misled and told untruths about the situation. And when I tried to correct that, I was absolutely cut off, shut up, and told basically to spoke out by the medical people. So you're getting an assessment, but you're not getting a truthful assessment. Now, how do we deal with that? Because I think that's really, really important, that you get to do the best job on the medical side. You need the best quality of information.
Oh, no, I totally agree. And we do get that in consultations, because even just something like the question about the level of alcohol, the patient might sit there and go, oh, yeah, I have a couple of beers a week or whatever. And then the relative's sitting there going, no, you don't. You drink like 5 cans a night every night. So, you know, we do take on board that information. And if someone speaks up and says, no, this is the real story, then we will then go back to the patient and say, you know, we're getting a different story here from your wife. And then sometimes they go, oh yeah, it is, you know, sort of thing. So we do take on board what relatives and carers are saying. And likewise, you know, when they talk about pain, you know, the patients sometimes will belittle the pain that they're experiencing, but obviously the partners will say, you know, you say to them, are you eating and drinking okay? And they go, oh yeah, I'm fine, I just have a little bit of a problem with this. And then the wife will go, well, they ate a yogurt yesterday. And, you know, so you do take on board, and you are getting a bigger picture of what's really going on. And then you can say, you know, is this correct? And you would turn around and go back and question the patient about it. And often they will kind of relent and admit that they have got problems, because acknowledging problems means there's probably something still wrong.
Yeah, I think, Derek, also, I was the biggest culprit lying to the health professionals. Looking back, you know, Sharon obviously had to work because we couldn't afford her not to work. So I was left during the day on my own. And what I used to do is she used to leave my dinner out for me to eat. And because I didn't want to eat it, I didn't want to upset her. So I used to throw it over the back fence and make the plate look like I'd eaten it. I mean, looking back now, that's absolutely crazy, but that's the reality. And also, when I went in the hospital, when the hospital's teams, and they were fantastic, was asking me questions, I was actually in a very safe place. I don't know whether you find this, Amanda, that some patients will, you know, when they're in front of someone like Amanda, who's, you know, knows everything about you and listens and makes you feel very special, you feel very safe in that environment until you go home. And then it's like a different story. And I think the caregiver, many a time, the health specialist just say to me, so how are you feeling today, Chris? I'd say, I'm feeling great, because I was in hospital. And then she'd say, I don't think so, Chris. What about last week? What about the week before? What about yesterday? You know, it was crazy. So I do think the caregiver has a big part to play.
Oh, definitely. And quite often I might get telephone calls from the relatives or carers to say, you know, they're really concerned about them. But obviously it's very tricky, because you can't really ring the patient up and then go, oh, your wife has said this. So you kind of have to manage it in quite a sort of diplomatic way, as a kind of just an ad hoc checking in sort of telephone call, without really letting on, you know, that their relative has kind of flagged up something, you know. So, yeah, because sometimes you find you support the relatives more than the patients.
But on the other hand, I've also had a patient that rang me up and said, can you do me a favour, Chris, and talk to the nursing staff, because they're telling my wife too much. And I said, so what's the problem with your wife knowing too much? It was because she was a manic depressant. And the problem is then she was taking that all aboard and becoming very ill at home herself. So, but he couldn't tell her that, could tell the staff that, because they were always together. So the team thought that that's what they wanted. So when I rang the nurse up, the CNS up, she made an excuse to separate them at any time they had to talk about that side of it. So I do think on both sides, Derek, it's very hard for the nursing team and the health, because on one hand, they might have someone like you, Derek, that wants to know everything, the inside leg measurements and everything, and question everything. Then you get another person that the patient doesn't want their caregiver to know everything, but then doesn't want to upset them by telling them they don't want to know everything. And the poor CNS is stuck right in the middle. And I think that's where the skill of a CNS can come out. Good ones, like Amanda, will try and find that situation and deal with it accordingly. bad ones can cause a lot of damage.
I think that's all a fair observation, Chris. And yeah, our experiences are very different. I think people who are going to the hospital where Amanda works are getting a top-notch, first-rate service from a an experienced and very good CNS. That isn't always the case in all hospitals. No. And of course, sadly, we can't divert all our patients to Milton Keynes. If that were possible, Amanda, you wouldn't be happy anymore. You'd be extremely overworked.
Especially if there's only one of me.
I was going to say, Amanda, what I have to say is with Amanda is, I hear a lot of people will say to me, yeah, but there's only one of me and I can't do everything. Well, there's only one of Amanda and she does everything. But other teams have got 2 or 3 CNSs, as we know, and Amanda will know, and they deal with a lot less patients than Amanda does. I do think sometimes the people that pay the bills, I don't think targeting is the right word, but I think that they should look at what people do and understand what is needed in a hospital. And, Amanda is on her own. Yeah, I know a hospital that's got 3 CNSs, and they don't do half the stuff Amanda does. So I don't think ever the number is an argument.
Well, let's ask Amanda. During your, the training to become the CNS, to fulfill the CNS role, is it a generic training, no matter where you are located around the country, that you're all going to be given the same lectures, the same, suggestions and signposts to fulfill the CNS role? And it's only when you get into your actual hospital and you start operating that you have some element of flexibility to change the role into what you believe is the right way to run it? Or are you told, no, this is the way you have to go?
No, I very much have control over my service in Milton Keynes, where I previously worked. So my background, I actually was quite late to nursing. I qualified in 2006. I'd had all my children, and went back to university and trained as a nurse and worked on a head and neck ENT ward from qualification, and really enjoyed it. Enjoyed looking after tracheostomy, laryngectomy patients, and the opportunity came up for a new role, and this has sort of started across the country really, was to have what they call a band 6 support nurse. So it's really just a band 6 nurse specialist, and that enabled me to take the practical skills of looking after the patients that have had major head and neck surgery, supporting them on the ward, and then taking that out into the outpatient setting, working along the band 7, who'd obviously got a lot of experience. So there were 2 of us. And then really you don't really get training as such. You kind of observe how communication takes place, learn from that, develop your own communication style. You go and have training in psychological support, and there's lots of sort of study days you can go on. I did some degree modules specifically in head and neck cancer and radiotherapy to give me a bit more sort of background to help with supporting patients in head and neck cancer. So yeah, it's virtually sort of a lot of it is experience, learning from experience, reflecting on past patients, and sort of you have the rough and the good and the bad days. You have very complex patients, and you have patients that are really easygoing and really sail through their treatment and barely contact you. So it's so varied in the role.
The Swallows Charity Head and Neck Cancer Podcast is designed to help and support both patients and caregivers.
I think, Chris and Amanda, I think there's a case here for saying somehow we need to coordinate the best of this role and make it almost a must apply across the whole country through the NHS. we've got people operating in this critical role who are forward facing. They are on the cliff edge with the patients and the caregivers, and whilst there's a generic method of helping, it's very much dependent upon the skill of the individual. And if we have a number of individuals who are doing a superb job in difficult circumstances and making the very best of it, how do we get that applied across all the other NHS outlets in the country?
Do you know what? We are a national health service, but we're a health service, really. We're not a national health service. And I think that's, you know, I've been doing this now since I got diagnosed, working with people like Amanda. And, you know, there's a lot of good teams. I think Amanda will back me up. There's a lot of people out there doing a lot of good stuff. And I mean a lot of good stuff. And when we bring them all together at our conference every November, it's surprising how they start networking and talking and understanding the different services. And it is a shame, Derek and Amanda, that we can't, you know, bring all these ideas together, because, you know, if it works in one hospital, it will work in another hospital. Whether then that's down to funding is a completely different subject. But if that works, why not have it in every hospital? And what they should have is they should have people like Amanda that they pay, that goes out and talks to other people about what they do, and then have relief that then deals with her patients while she's out. But, you know, we have a lot of nurses, a lot of consultants doing some fantastic stuff, and we do need to start sharing it. And that's why hopefully at the conference we do every year, we can bring that together. But I've been reading this morning, because I'm doing some work around NICE and the multidisciplinary team around psychological involvement within head and neck multiple interdisciplinary team. And you know what? I found the document called National Institute for Clinical Excellence, which was written by NICE, which is a NICE guidelines for head and neck cancer. And you know what? In there, their top person says that NICE say that in every multidisciplinary team, before they even talk about surgeons, by the way, is our CNS role is the most important role within NICE guidelines. That tells you how important the role that Amanda does. And if nothing else, that's NICE, that, you know, people like the NHS have to report into. So, you know, if there's only one and Amanda needs two, actually in the NICE guidelines says she should have assistance. Mm. It also says in NICE guidelines that the CNS role, best practice should be shared amongst all other CNSs. So it's not us saying it, Derek, it's NICE. And if someone really wanted to be really funny about this, NICE is the one that guides the NHS. So there is backup there for people like Amanda, but they are so busy, bless them, they haven't got time, because every time they get involved in anything like this, a patient is not being seen or not being helped. And that isn't in Amanda's nature. So we've got to take those battles on, Derek, and it's certainly a battle I'm going to take on behalf of all our CNSs and psychologists, because I think you'll agree with me, Amanda. I think a psychologist should be right at the heart of every MDT for head and neck, during and post treatment, because of the quality.
We do have a Macmillan psychologist. We didn't for a while, because the idea is that, you know, we manage them to a point, but obviously some people do have far more sort of psychological needs, maybe mental health issues in the background or in the past. So our psychologist is really important for those more complex patients. So I certainly sort of forward out to them. We've also got a new community service as well for the sort of long-term palliative, but obviously not necessarily symptomatic, that again out in the community can access dietetic, physio and also psychological support, as well as any symptom management that would run alongside them still being followed up in a clinic. So that's a fairly new service that I've been able to access after meetings with the team that were setting it up. So they were happy to take the head and neck patients.
That's good to hear. That's good to hear, and I think Chris will support me here. I've been a long-term advocate of having psychological support during this journey. Just on a very personal basis, when my wife was going through her treatment, which involved huge surgery, 13 hours of surgery, a few days in intensive care, and then 27 days on the ward to recover, and then it represented in exactly the same place about 2 months afterwards, before radiotherapy had started. And not once during all these traumatic occasions did we get any support, help, or offer of any psychological, where we were going through the most horrendous time, with no support at home. When we were thrown out of the hospital and sent home, no community support whatsoever, just abandoned. It felt like you'd been abandoned. Our fairy godmother, and this is how I think of you, Amanda, our fairy godmother, and it doesn't have to be it can be a fairy godfather as well, and it was in our case. The CNS that I was dealing with was always available when I phoned. There were two of them working in tandem, so they sort of shared shifts across the week, and both were available, and they were our lifeline. And if I needed to know something or needed some support in some area, they were the only person. You were the only person I felt confident about calling and talking to. Besides which, most of the other people in the team don't want to talk to you outside of the official appointment time. So you're the guys that cop all the outside telephone calls and all the mobiles, which I also think is a little bit unfair, because it's another burden on you which ought to be shared across the whole team. Or am I missing the point here?
No, I mean, I think for me, I find it so important. I mean, obviously I have a cancer navigator now, and she's brilliant. So whereas I used to be in clinic and come back from a clinic at lunchtime and find I'd have a stream of messages on my answer machine to then deal with, I now do have somebody that will answer the phone. They can ping me a text or an email to say, can you ring this person back? So in gaps in the clinic, I can potentially call that person back a lot quicker than when I used to go back after a clinic and just have these mountain of messages. But it's also important for that patient to just have a voice when they answer, and not just an answer machine message. So that works really well, and there's been really good feedback about that. And also they can kind of sort things out. If it's just an appointment inquiry, then they can get on and do that, and I don't necessarily have to be involved in it. So that's really key. I do have a colleague who has a fantastic role like myself, but his role does enable him to follow patients out into the community. So where I previously worked, where they were the surgical centre, his hospital fed into that hospital for their surgery. So when they were discharged, he was able to go out and see them as soon as they were discharged to see how they were getting on after their surgery. So, but his role is funded jointly between the community and the hospital, and I think that's a fantastic role, because it just enables him to have 3 days in the hospital, 2 days in the community. He can see a patient for breaking bad news, and whereas I have a holistic needs assessment clinic, he can go out and see that patient in their own home and allow them that time to have digested the information, see them in their own environment, see what their social setup is and the support that they have, and support them in that aspect of their journey, which I think is brilliant. And I think that actually should be across the board.
Yeah, it's the usual thing, Amanda. It sounds amazing, and it ought to be available across all hospital trusts. It just isn't, and so there's I hate to use this phrase, but it is almost like a postcode service. Depends where you live, depends what service you get. Listen, there's no doubt about it, Amanda. You do a fantastic job, and Chris is obviously a great admirer of yours. So I'm sure he's going to leave you lots of money at some point as a result of his admiration. But let's just ask one more question. Chris and I are your fairy godfathers, and we can offer you one wish with regards to your job, your role, your function. One thing that we could change for you that would make your life better, or your job function better, or give you a service that you don't currently have. What would you ask for, Amanda?
I think it would be to have an extra person. I think that's something I know people are probably getting bored of me saying, but I just do think that sometimes the sort of challenges we face, I think sometimes I feel I may be impaired in giving someone as good a treatment. I always feel bad if I'm not able to give 100%, just because of the amount, if I'm so busy and the complexities of things. And I just feel that it would be good for the patients to have an extra person, and we can kind of share the caseload, and I think that is important.
How many hours a week paperwork do you do?
Yeah, so today I'm working from home, so I'm sort of catching up on paperwork and prepping sort of for tomorrow. So I would say probably a couple of days of paperwork sometimes. Just depends on how busy things are. But with COVID, everything seems to have gone a bit mental in the last few weeks.
Yeah. So on that, I know another CNS who's finally got some funding for someone to assist her. But what she won the battle on was the fact that she would have a lower grade person to do that paperwork for her. Mm-hmm. So the paperwork, it was like 2 days a week, but what she was doing was almost as an assistant, not a full-blown CNS, but it was one to take care of some of the paperwork, to take some of the initial phone calls, to try and triage a little bit more, and build up their experience to become a proper CNS. Like you say, you can't beat experience. You know, if we could cut you in half and spread you around the NHS, it'll be wonderful. But, you know, you can't buy that experience, Amanda. So having someone that works alongside you, building up that experience, whether they're a trainee or whatever they may be, but also taking care of some of that paperwork, would that not give you your wish? Would that not be a starting block?
I think they just definitely need to have a nursing background. I know these band 3 and band 4 roles that have been put into place. You know, yes, they can do paperwork, they can signpost people to, say, stop smoking services, but when it comes down to obviously the complex psychological needs, it's having that awareness of who needs to be involved. And, you know, so yes, in terms of paperwork, for example, I've got a couple of patients that might need a referral out to palliative care. You could have somebody that does just the general filling in of the paperwork, the contact details and everything, and then all the CNS would do was actually put in the detailed information of what that person's diagnosis and needs are at that point in time, and what's been done in terms of symptom management. So I think from my background, going from a band 5 nurse on the ward, moving into a band 6 and learning that role, and then from experience being able to then go to a hospital that didn't have a head and neck nurse. So I'm the first head and neck nurse. I've not even stepped into somebody else's shoes at Milton Keynes, to sort of set up the whole service and work out how the land lies, liaising with everybody. And now I do my own nurse-led clinics for thyroid cancer follow-up, as well as the holistic needs assessment. And my plan last year before COVID was to start to learn to use the flexible nasendoscope and start to sort of examine patients and follow up people that were a bit further out from their treatment, sort of heading more towards discharge, to just help relieve the sort of consultants, because you've got new people coming through all the time, and we follow up patients for 5 years. So there's that role is developing, that nurses are taking on more and more responsibility.
Amanda, Derek, I don't know whether you just listened to that like I have, Derek. You know, she's a psychologist. if she could do surgery, this woman would do surgery. I mean, and you know, there's a lot of CNSs out like that, you know, and now she's already said to us she could do it another person, and now she's telling us she wants to look at doing other things within that role, and it's like, that's what our CNS team are like. And you know, I think you had a great CNS, and you know, I'm lucky enough I've met an awful lot of them, but you know, that to me tells me everything, that we've got hope. We do have characters. I think that's the best way of putting it into hospitals. Some of our surgeons are very, very strong characters and like to do it their way, which, you know, curing cancer is what it's all about, and we never want them to stop that. But I do think our new generation coming through will realise this bit about quality of life is just as important as curing the cancer. And, you know, bless her, Amanda takes it all. And so do a lot of other CNSs. And thank God, Derek, we have our CNS team.
Oh, absolutely. 100% agree. And Amanda has just reinforced my own belief in the role of the CNS from what she said. I would say to people who are listening to this podcast and who are starting their journey, the cancer treatment journey, the CNS is your number one contact. Get to know your CNS. Okay, and share your thoughts and your issues and your problems, your highs and your lows with your CNS, and they will look after you. They'll wrap a big arm around you, a bit like a mother hen. This big wing comes out and it wraps itself around you, and Chris has already alluded to this. You feel safe. You're in good hands. And yes, so it's surgeons that are going to do the operations, and it's oncologists that are going to be doing, you know, and it's pathologists that are going to be doing that. But at the end of the day, the person that is going to look after you the best is going to keep an eye on you, is going to guide you and steer you, hopefully in the right direction. 99%, if not 100% of the time, is your CNS. So make sure that you have a good relationship with them. Fair to say, Chris?
Yeah, fair to say. And what I'd like to say, though, to Amanda now is, who looks after you?
Well, our psychologist is very good, actually, and we can access her at any time. And I'm quite sensible, and I do that. And if I do have any patients where I think, well, I might be struggling to manage them, I go and talk them through with her. So she'll either say, no, I think Amanda, I should see them.
You are just like a caregiver. When we ask a caregiver about them, they go on about their patient. I said, who looks after you?
You do have a point. You do sometimes reach a breaking point, and I have some excellent colleagues around me, you know, whereas, like we said, if you had another fellow colleague in the same team, yes, you would bounce things off each other, you would take it in turns to deal with a complex patient. But sometimes, you know, you shed tears, you know, things are really emotional, and certainly if there's someone that you've been quite heavily involved in, and they're almost reaching the end of their 5-year follow-up, and then they get a new cancer. I mean, I've come across somebody who was like literally 6 months off from being discharged and got another head and neck cancer. And, you know, you just don't know what to do for those people. And, you know, it can be you've followed them through for those 4 years, and you think they're heading off into the sunset, and, you know, and then these things happen, and, you know, sometimes you could cure them again, and others it's the end of the road, and it's really, really sad. And, you know, we do have our limits. You know, we're not Superman. You know, we do all have emotions and everything. And I think sometimes, you know, with some of the patients I've had, I've even shared tears with the families and the patients, you know, because it's been that sort of relationship that you've had. You know, and when you're coming to that final decision about, do you know what, I've had enough of treatment now. I think, you know, it's quality of life versus length of life. And I just want to go home and spend the rest of what I have left with my family. And you sitting there and you're part of that conversation, which is a privilege to be. How can you not be touched by that? How can you not show any emotion in that situation? I can feel myself welling up now because I can visualize the conversation I'd had with that patient who did sadly die.
I can share all that emotion with you, Amanda, because that's exactly what I went through. My wife was diagnosed as terminal, and we went through that, and the CNS was there with us. So were 7 other people who we didn't know very well, particularly. I think that's a poor sign when 7 people stand in a room. You know, you're getting bad information coming your way, but the CNS was there, and the CNS we all shed a tear. And when everybody left and departed, it was the CNS that stayed behind. It was the CNS that sat with us. It was the CNS that wrapped their big, warm, cuddly arm around us and just sat there. We didn't have to speak. Sometimes it was just we sat there together. And and the tissues come out, and you deal with what you have to deal with. But as Chris has already pointed out, Amanda, you've drifted straight off yourself onto the patient. We asked you about yourself, you talk about the patient, and you've done it again. Chris, sadly, we're coming to the end of this particular episode now. It's time to wrap it up. So. First of all, I'd like to give a huge thank you to Amanda for joining us today. You are an inspiration. We love you dearly, and not just you, Amanda, all CNSs. You all fit into the same category for us. You're a vital stage in the treatment pathway, and God bless you. Stay safe and look after yourself. And a huge thank you for joining us today and sharing some of the ideas and thoughts and things that you do to make the journey for both the patient and the caregiver just a little bit easier.
Yeah, I think very honoured. I'm very honoured to have known you all this time, and I can't believe it was 2016 when we started on this journey. 2016, Jesus, I can't believe that. But I'm honoured to have known you. I'm honoured to know you now, and I can't wait for the future. Continue to work. Thank you for coming on here and speaking so well about the CNS journey. And I think all the CNSs who listen to this will be very proud how you portrayed that role.
Absolutely. Yeah.
So,
agreed.
fantastic. And thank you very much for coming on.
All right. Thanks, Chris.
Thanks, Amanda. Chris, as usual.
If you want to contact the Swallows, it's www.theswallows.org.uk, or you can email us on info@theswallows.org.uk. We're on Twitter, which is at the Swallows Group. We're on Facebook. And the most important part is our 24-hour support line. It is for patients and caregivers. It's not a call centre, so please call. Sharon, my wife, who's a caregiver, will always answer that phone no matter when you ring. If you're a patient, she'll pass it over to me. And if you're a caregiver, you can continue to talk to her, because I don't talk to caregivers, as you know, Derek. They're a funny breed. But the number is 07504 725 059. So please get in touch whenever you need us.
Thanks, Chris. As usual, very concise and long-winded. We've got episodes coming up. We're going to talk to Macmillan head and neck cancer support worker. We've got a few more episodes that we'll be talking to some of our pharmaceutical company support groups out there that provide us with vital supplies. And of course, most importantly, sometime in the near future, we're going to be talking to some family members of caregivers on the impact of finding out that a member of your immediate family is on this journey, and how it impacts on you. So thank you, everybody, for listening. Take care. Be safe. Bye, everybody.
Bye.
You've been listening to the Swallows Charity Head and Neck Cancer Podcast. For more information, please visit www.theswallows.org.uk. We hope you'll join us again next time.